Good morning. My name is Dr. Deirdre Hayes, Professor of Practice at Tulane School of Social Work. Welcome to the Tulane School of Social Work's virtual Elk Place Health Spot. Pre-COVID, the Health Spot was a monthly in-person health fair held in front of the School of Social Work. The busiest bus stop in the city is in front of our school. So wasn't it great that our dean, Patrick Bordnick, had the great idea to bring information and services to the individuals who ride the bus and use the corridor to access downtown New Orleans. The Health Spot provided STD testing, dental screenings, and assessments for substance abuse and mental illness. In addition, the Health Spot served to provide information on housing, voting, and multiple services available to the community. We actually had one day when we registered 33 people to vote, which was our all-time high in one day. Although COVID has interrupted our in-person service delivery, we continue to provide information on relevant issues of the day. Today's topic will be mental health and the justice system. According to the Bureau of Justice Statistics, 14% of individuals incarcerated at state and federal prisons and 26% of individuals in jails meet the threshold for serious psychological distress. This is 3 to 5 times higher than the general population, which is 5%. In addition, individuals who have serious and persistent mental illness are more likely to be victimized and further traumatized in the criminal justice system. The Elk Place Health Spot, in partnership with the Empowering Change Task Force, is presenting this webinar on mental health and criminal justice system to explore the connection, its impact on our communities, and what can be done to support those experiencing mental health crisis. Our team today, Carrie Mulder is the TSSW Marketing and Media Specialist, Lawrence Perry, TSSW MSW student and will be graduating at the end of this semester, and myself, Dr. Hayes. Our speakers today are experts in the field and will share current information about the mental health system in New Orleans. Lawrence Perry, student at TSSW, Dr. Serena Chaudhry of EPIC-NOLA, Judge Kern Reese, civil court judge, Ginger Parsons of the Orleans Public Defender's Office, and Dr. Sarah DeLand, who is a forensic psychiatrist in the city. Please welcome them, and we will begin with Lawrence Perry, our TSSW student. Thank you, and once again, welcome.
Good morning, everybody. Give me 1 second while I share my screen. Good morning, everyone. My name is Lawrence Perry. I am currently a Tulane School of Social Work student, graduating in December with my MSW. I'm just going to give you a brief overview of what the topic is going to be about and how mental illness and the criminal justice system go hand in hand and how they work. So let's first talk about what is mental health. The Webster Dictionary defines it as a condition that affects your thinking, feeling, mood, and behavior. They also associate with long-lasting chronic. They can also have your abilities to relate to others and function every day. People who have mental health issues, as a social worker, we look at the DSM, which is a Diagnosis Statistical Manual of Mental Disorders. So it is this book right here, actually, that we all have to look at to diagnose people with proper diagnosis, to help psychologists and psychiatric doctors when dealing with people who have mental health. We also help with deal with patients and clients who suffer, not them, but also their families. So what is considered a persistent and mental illness? There are 4 categories that are considered to be serious and persistent mental illness. The first one is major depressive disorder, bipolar disorder, schizophrenia, and borderline personality disorder. These different ones are major, and they are very persistent because they are the ones that last the longest. Some with some mental illnesses, they do come and go, but with all these types of depressive, all these different types of disorders, it continues throughout the client or the patient's lifelong, and they live with this for the rest of their lives. So let's talk about how does this work with our criminal justice system. In the early 80s, in late 70s, many of mental health institutions were shutting down due to government breaks. So many of these individuals roamed the streets, couldn't find support that they need, or they went to jail because people, their families, society did not like to care for them. So as of right now, 60% of adults in a small local jail, so take New Orleans, for example, have suffered from a mental illness. 13 million of those people who are in the jail altogether in the United States, about 2 million of those people have mental illnesses here in America. Many of those people in these institutions do not get proper treatment for their issues due to the fact of budget cuts, or they are overpassed with their illnesses or properly undiagnosed. Many of these individuals do not know how to ask for help, or do not know how to control or have a good baseline for them so they can go about their day-to-day lives. How can we end this cycle? There's a couple reasons I figured out that we can end this cycle, and doing research on my own, how we can break this prison cycle. So many of our youth and many of our adults who go into the system can go into the prison system can get help. So my first one is keeping people out of the juvenile justice system. I say this because if you maximize the division of a person with a serious mental illness in the criminal justice system, it's crucial to reduce the financial health and the human costs of the incarcerated. Most of these people need a more positive structure instead of putting them in jail. Many of officers, police officers, law enforcement do not know how to handle people who have mental illness. The first people that we call if somebody's having an episode or a mental breakdown, we call the police. So many of those police officers may enrage the client or the patient when they're having an episode, and it may become dysfunctional, and they may do something else to the officer, to the family, or to the situation that may hurt them when they go, if they are arrested or go to court due to the fact of their mental illness. Another way we can do it is to support the people that we serve. Youth and adults in the juvenile justice systems have the right to access mental health services. Many people here in the United States don't have access to mental health services. This includes going to a therapist, getting proper medication, having counseling groups with other individuals that have the same mental illness as them and talking to them. That goes inside with a lot of different things. But we need to support these individuals, their families. Some of these individuals that are incarcerated, they have their family support, but they don't have their families because they're behind bars. So they don't have their support because that's also taking a toll on them due to their family, their loved one is in jail and they can't really do anything about it or help them with their mental illness. So we need to find a way to support them, the family, and also the individual who is suffering from the mental illness. And my last one, one of my last ones is eliminate discriminatory practices and punishments. So many of those individuals that have mental issues or mental illness, they have, they're treated wrongly. As you know, you've seen in movies and stuff like that, or the media, that you see that individuals are treated harshly, they're abused, raped, tortured, all that is not innate with having somebody who have mental illness. We need to treat that person because at the end of the person, that is a person at the end of the day. And being a social worker or an upcoming social worker, it's in our code of ethics to know that though the person has a right. That is a person at the end of the day, even though they do suffer from mental illness. We need to come together to also put these people who are having these serious issues into place, and try to reform that as best as we can. And the last thought I had, we all need to come together as one. So in order to reduce involvement, support those who need services, and promote fairness throughout the criminal justice system, leaders in the mental health system, law enforcement officers, public defenders, prosecutors, court personnel, advocates, legislators, and others in the criminal justice system must come together to create a system that will improve outcomes for all. It's not just going to start with one individual or one case, a judge, a prosecutor, a social worker, or a psychiatric doctor. This has to be a team effort so everybody can come together on the same page, try to improve. Like the famous saying goes, Rome wasn't built in a day. And it takes, there's no I in team. So we all need to come together as social workers, as people who deal with social workers, as prosecutors, law enforcement, public defenders, to try to change this justice system that is in the jails. So those people who have, who are incarcerated right now, who suffer from mental, can get the proper treatment that they need. So hopefully this will inspire you to go and vote as of next Tuesday, or if you haven't done voting already, because this is a big thing, so we can have right people in those offices. And also looking at trying to do your part as a citizen, trying to help these people or their family members that you may know that are suffering from mental illness. If you have any other questions, my name is Lawrence Perry. I am, like I said before, a student here at Tulane School of Social Worker. I have attached my email to the PowerPoint. If you have any additional questions, I am more likely to have to help you with that. Thank you guys so much.
Thank you, Lawrence. Next up, we have, we have Dr. Serena Chaudhry. She's an LCSW, and she's the clinical director for EPIC-NOLA, which is Tulane's Early Psychosis Intervention Center. And she has brought along Nicole Dent as her guest.
Good morning. Thank you, Carrie, and thank you, Lawrence. I appreciate your plug to encourage people to go vote. My name again is Serena Chaudhry, and I'm a licensed clinical social worker. I am the clinical director of EPIC-NOLA, the Early Psychosis Intervention Clinic. We're located in Mid-City in New Orleans, and we're part of a Tulane specialty psychiatry clinic that co-hosts another specialty psychiatry clinic called Fourth Trimester. Our specific clinic is focused on helping individuals who are presenting with their first episode of psychosis. So psychosis, for those of you who are unfamiliar with it, can be the start of a serious mental illness, and the serious mental illnesses that Lawrence cited in his presentation: bipolar disorder, major depressive disorder, and schizoaffective or schizophrenia. We can often see psychosis as a symptom along with those diagnoses, and the onset of psychosis, as Lawrence stated, can be the signal or the red flag of a chronic and persistent mental illness. Psychosis is, just to clarify and to put into easily accessible terms, psychosis involves losing touch with reality and not really being able to see what's real and what's not real. And psychosis symptoms usually happen to people under the age of 35, and the onset is typically between 15 and 25. So that age group comprises the majority of our patient population. Psychosis can present in many different ways. Some symptoms are hallucinations, so seeing or hearing things that aren't real, false beliefs, believing things that aren't known to be possible, lack of mental clarity, so people's minds playing tricks on them, loss of interest, change in personality, disconnect or isolation from friends and family, suddenly doing worse in school or on the job. So those can be the red flags for the onset of many mental illnesses, but specific to psychosis. So once someone is presenting with these symptoms, in a perfect scenario, we have a family member, a friend, or community member who observes this and refers them to our clinic for an intake and assessment to see if they are the right fit for our clinic. Unfortunately, what happens the majority of the time is people experience psychotic symptoms and they intersect with either the hospital or the law, and then they come to us after they are incarcerated or hospitalized. Once they come to us, regardless of the pathway to care, we're able to provide a what's called a coordinated specialty care. And coordinated specialty care is sort of within its first decade of existence in the United States. It came out of a movement in Europe and in Australia, which has been ongoing for the past 30 some years. And basically it is bringing together a multidisciplinary team to provide a range of services to individuals and families upon that first episode of psychosis. So we have a team of psychiatrists, medical doctors, DOs, we have licensed clinical social workers, LPCs, we have a peer support specialist coming on, someone with lived experience, as well as medical students and social work interns, all providing care for people when they arrive at our clinic. The three-pronged approach initially upon someone landing here is that they get low-level psychiatric intervention with medications to help manage and mitigate their symptoms. They, when they're ready and consent, are referred for individual psychotherapy, and then families are provided with psychoeducation to help them understand where they've landed and what's been going on. Most often people come to us very confused and often traumatized by an incarceration or a hospitalization. And our goal is to help them feel safe, help them understand what's happened, and give them a comfortable landing in this clinic, where our hope is to help manage their symptoms and move them towards recovery. So the whole goal being to provide treatment, but also to reduce the duration of untreated psychosis. So we have our clinic, which I just described, along with our psychosis awareness campaign, which is called Clear Answers to Louisiana Mental Health. And our goal is to educate people on these symptoms that I've just reviewed, help them to understand how psychosis presents, and help them, as I said in the beginning, get them to us prior to being incarcerated or hospitalized. What I'm going to do now is hand the screen over to one of our super moms, Nicole Dent, who is going to share with you her story of her son's journey and intersection with many of these symptoms. Thanks, Nicole.
Good morning, everyone, and thanks for inviting me. My name is Nicole. I have a son who is 24 now, and he has been diagnosed with bipolar 1 since 2017. He was away at college in Chicago at DePaul University, and he just began, his behavior was not like himself, and he became, he couldn't talk to me. He couldn't convey a thought to me. He couldn't speak to me in clear sentences. So I had him come home, and he was admitted for the first time. The first year was really rough, but I want to say maybe after 6 months of being in and out of the hospital, he started taking medication. We were referred to EPIC-NOLA, which was a godsend. They've been like a great support throughout these last 3 years. This year has been really crazy for us. I can't count how many times my son has been hospitalized this year. He's been in a dual diagnosis treatment facility 3 different times, 3 different ones. One in Lafayette, Louisiana, and it didn't really help at all because they focus more on drug and alcohol addiction than the mental health part. And then I sent him to Florida to a place that was supposed to help with both addiction and mental health. But every time he came home, it was like, I don't know if he was upset or he was mad because he was there. But when he came home the second time, he came home in April. In that first week, I think he was hospitalized twice. In May 10th, Brian was taken to the hospital by NOPD. And NOPD called me to let me know because there was a missing persons report out for Brian because he had been missing for a couple of days. They found him. They took him to the hospital and they called me to let me know he was at the hospital. So I went to sleep. It was actually Mother's Day. I went to sleep that night I felt better because I knew he was in the hospital and that he should be safe at the hospital because the police took him there. And so he must be on a psychiatric hold. However, at 4 a.m. in the morning, my son, Brian, was knocking at the door. He had walked home from the hospital. He was lethargic. He was high off of something. I don't know if it was what the hospital gave him or if it was something he took. But at 3 o'clock in the morning, he walked all the way home from the hospital. And I thought he was in the hospital. So anything could have happened to him and I would have never known. And I probably wouldn't have thought to get concerned for a couple of days because had I called the hospital, I wouldn't have been able to talk to him because I wouldn't have had a password to get through to him. So he ended up coming home with needles. So no one was watching him in the hospital because he stole needles from the hospital. And I guess he tried to draw his own blood with these needles. May 14th, the police took Brian back to the hospital because they found him 10 stories up on a building on the ledge. So they thought he was trying to kill himself because he was standing on the ledge of a 10-story parking garage. And the hospital let him back out a few days later. On April 25th, he was readmitted into the hospital and he stayed for a couple of weeks. And then they sent him to 5 hours away to a place called Lark. And Brian got there and he said the people were mean. It felt like jail and he didn't want to be there. So in his mind, he thought the best option was to walk out of that facility 5 hours away from home and hitchhike to the next city so he could catch a bus home. But when he got there, the buses weren't going to be leaving until the next day. Someone called the police on him because he looked, suspicious. He was a suspicious character. So when the police came up on him, they found that he had a warrant or a fugitive of justice warrant in New Orleans. So he was kept in Monroe, Louisiana for 10 days. And he was scared. He didn't know why he was there. I didn't know why he was there. I didn't know because I had so much communication with the police and they never mentioned that he had a warrant or that he had done something. But between May 10th and May 25th, sometime around in those 2 weeks, Brian was fixated on glass and believed he could turn glass into diamonds. He bust out a business window and it's on camera. And now he has a felony pending against him for busting out the window of a business. It was very traumatic for him to stay in jail for 10 days. He's never done anything remotely close to breaking the law in his life. I mean, he smoked weed, so I guess that's illegal. But other than that, he's never destroyed anyone's property. And so now he was in jail for something he didn't even remember doing. He went to another dual diagnosis treatment facility after that. So around maybe June 20th, 25th, he went to Florida to another dual diagnosis treatment facility. And in hopes that, it would help with whatever alcohol issues, drug issues, and mental health issues he's dealing with. And then Serena shared with me the AOT program, which I felt like is a great fit for him because he's struggling. He's struggling with getting to his appointments. He struggles with medication compliance, and he ended up in jail for something he couldn't remember doing. So I thought that that should be the premises for someone to be accepted into a program that would give them an extra little push. Unfortunately, he was denied the AOT program. And yeah, that's where we are now, trying to get him into the AOT program. And it's just, I'm a parent who's just wondering what has to happen before his condition is taken more seriously. From my viewpoint, I think things could be a little bit different if the medical, like if the hospitals did a little bit more due diligence with the patients that come in. And I know it has a lot to do with funding and it not being enough room to service everyone. But if you have someone there just making sure they're stable before they go back outside, could alleviate a lot of these people ending up in jail. Because from my experience, my son has been released from the hospital so many times and he's still delusional. So that's what I have to say. Thank you, guys.
Nicole, thank you so much for sharing that story. We really appreciate it because what you have given us is a picture of what parents go through. This is what parents go through who love their kids, who need help, and who need a continuum of care. And Nicole's story demonstrates that. So thank you very much. Now, our next speaker is going to be Judge Kern Reese, who will talk about AOT, which Nicole just introduced to us.
Thank you, Dr. Hayes. Thank you, Nicole, for sharing your story. One of the reasons I helped initiate this program at Civil District Court was for a number of years, I watched mental health treatment facilities diminish in the state of Louisiana. As a duty judge, we would do judicial commitments pretty much on a quarterly basis. And I was seeing consistently that there were no beds for treatment. And I was wondering, what could be done to remedy that situation. And I came across Louisiana Revised Statute 2866 at SEC, which was named for Nicola Cotton, a police officer who was killed by a mental health patient in 2008, who really should have been hospitalized or in an inpatient facility at that point in time, but instead was on the streets and was not properly medicated. The statute allows for individuals who are 18 years old, who are present in the jurisdiction where they are, who suffer from a mental illness and has been diagnosed, and who has been hospitalized pursuant to that mental illness twice within the last 36 months. Those are the criteria. And individuals that can file an AOT petition, or the head of a hospital, the medical director. Wait a minute, I have a copy of the statute here, and I'm sorry. If I was more technologically proficient, I would put it up on the screen for you. But if you look at Louisiana Revised Statute 2866, it's readily apparent there. And the individuals who can file are the doctor, director, administrator, treating physician of a hospital in which the patient is hospitalized, the director, administrator, treating physician of an emergency receiving center in which the patient is receiving services, the director of the local governing entity or his designee in the parish in which the patient is present or reasonably believed to be present, any interested person through counsel with written concurrence of the coroner of the jurisdiction in which the person is found, or the Louisiana Department of Health. And we have initiated this in Orleans Parish. I have to give credit to Ms. Janet Hayes of Healing Minds NOLA, who has mightily assisted in founding this program and keeping it running. We suffered a few setbacks. We got funding from the city of New Orleans, and we had an AOT coordinator, but because of the pandemic and diminution in funding, the city had to withdraw its funding from the program. So we lost our coordinator. We have participants in the program, and we are looking for referrals because, I believe we're quite capable of managing a number. When we presented to the city council, we told them there are a number of individuals who are recurring, and that's the nature of mental illness. I'm finding that individuals who don't follow a treatment regimen, who don't probably take their medication, are going to be recurring patients in facilities. And our goal is to keep people from having to go back time after time, to reduce the stress on the families, to assist the person in every way we can when they come into the program. The optimum scenario for AOT, I found, is that we want them to come to us and have a petition filed, bring them into the program right after they've been released from a treatment facility where they're stabilized, where they're on a medication regimen, and where they are ready to live better. And then once they come to us, we set up a treatment plan, which is called for in the statute. An ACT team is assigned to the individual because they're usually eligible for ACT team services. And the ACT team is responsible for helping the person get to any counseling sessions that they need to get to make sure that they are taking their medication properly, to assist with any social issues, housing, employment if possible, or income generation from whatever source, governmental or wherever, and just to try to keep the person as stable as possible. I have two individuals who started in the program last year, one in May and one in June. Literally took court to University Medical Center and had the initial AOT hearing there. Got them enrolled, got them participating, got them an ACT team, made sure they took their medication. We had to amend their treatment plan periodically just to tweak if one's medication needed to be reduced or ACT team needed to be replaced or some other issue came up. We dealt with that. I'm happy to say that they are successfully going through the program. We were gonna graduate them after about a year of participation. Pandemic slowed that down, but I anticipate them coming to AOT court in November, where I can give them a certificate of graduation. There's a very renowned judge, Judge Oscar Cruz in San Antonio, and he was graduating his first AOT participant, and he didn't have anything to give him. All he had in the office was donuts, so he gave him a donut. So that became their tradition. In San Antonio, when the person graduated, they got a donut and a certificate. Well, I say this is New Orleans. I was going to give them beignets, but that really got unmanageable with the powdered sugar. So I'm going to have to find something else to give to our participants when they graduate. But when it works very well. One of the young men who's graduating is doing very well. He started his own business. He has participated in movie productions and television productions, and he's living a very normal, stable existence and has not been back in the hospital since he got into AOT. And that's the goal. That's what we want to achieve. That's what we want to accomplish. Now, AOT is not a criminal program per se. It's in civil court. The only teeth that I have in this program is that if a person does not continue their participation, I make a report to the State Department of Health and say that they may be decompensating, and as a result, they might need a judicial commitment. But, you know, the black robe effect is what I function on, where I bring people into court. They know I'm the judge. You know, we show an interest in their care and are supportive and try to keep them interested and maintained and supported in every way in the program so that they can continue on with their regimen and stay stable. And when we get folks invested, it works very well. That's been my experience. And I'm going to continue it. In Orleans Parish, I've gotten the support of my colleagues here on the bench. I'm the only section that handles AOT. There is no charge to file a petition. The clerk's office, Ms. Chelsea Napoleon, has agreed not to charge, just like for a judicial commitment. And we're hopeful of obtaining state funding to assist the program with a coordinator, a game, and other possible services. And we're waiting to hear if that's going to be successful. So, you know, we want this to continue. We want people's participation. We want to reduce the number of recurring patients who have to constantly return to hospitalization because it benefits everyone. It's less stress on the families. It's good for the individual, and it's a cost-effective means of maintaining folks. And we want to keep it going as long as we can. And it's the law. So with that, I'll conclude my comments.
Thank you so much, Judge Reese, for that lovely and interesting and informative presentation. Next, we have Mrs. Ginger Parsons. She's an LCSW Supervisor Social Worker for the Orleans Parish Public Defender's Office.
Hi, thank you, Lawrence. Again, yes, I'm Ginger Parsons. I'm a licensed clinical social worker, and I am the Client Services Division Supervisor at the Orleans Public Defender's Office. So what the Public Defender's Office does in New Orleans is it takes a holistic view of our clients, how all of their life that they're living affects the way that their case may come out, the way that they get involved in the criminal justice system in the first place. And then we try to help them to get more stable in their lives so that they can stay out of the criminal justice system, hopefully exit and never come back. About 85% of the people who come through the criminal justice system in New Orleans are our clients. So that tells you that there are a lot of poor people who are going through the criminal justice system in New Orleans. The problem with getting involved in the justice system here, either the criminal justice or the municipal system, is that once you're in jail or once you have the charge, it's hard to get you out. And unfortunately for people with chronic mental illness in our community, sometimes getting taken to jail is the alternative to getting taken to the hospital. So they may have done something like Nicole was talking about, her son breaking a window, and that can be enough then to charge someone with a crime and take them to jail. And so I think the police have done a lot of training around recognizing mental illness, but they still may not always realize in that moment that this person needs to go to the hospital instead of to jail. And so people are arrested and have charges brought. A lot of times too, a lot of our mentally ill people in New Orleans, I have to say, are homeless. Housing's a problem here. And so, and when you're unstable and you're not on your meds, or you're taking your meds on and off, or you're not quite sure what's going on, you end up living on the street. And that also can lead to a lot of arrests. So there are a lot of misdemeanor arrests that happen because people are blocking the sidewalk, because people are misbehaving somewhere in public. And so this ends up with them coming to jail, and they become our clients. Last year in 2019, I think client services in the Public Defender's Office handled about 917 clients, and 58% of them, so that's like 500 500, a little more than 500 had a chronic mental illness that they identified to us when we first met with them. So there are a lot of mentally ill people ending up in the jail. And these are the people that get sent to us by the attorneys because they know they need some extra help with something in their life. So there are probably a lot more that we never meet who are coming into jail. And one of the problems with the jail and with people with mental illnesses, it's not set up to treat mental illness. There is a medical staff there, but they have a very limited budget. So people may have been taking their meds, a certain meds in the community, but the minute that they come into the jail, the doctor may have to decide to put them on a different medication, on a generic medication or something that's less expensive than the medicine that they were getting in the community. So sometimes, even though people may get medicated in jail and begin to see some lessening of their symptoms, once they leave the jail, they want to go back on their regular meds, the ones they were taking before they were arrested. So and anytime you switch medications like that, there are going to be unknown consequences. Sometimes people destabilize. So it can be a real problem just because of budget concerns. So, the other thing I would say is, so what is happening when we get people out of jail? Because this is our job as public defenders, is to try to get people back into their community. What we're seeing, number one, is a housing problem, right? Because people who are stable, if they're stably housed, it's much easier to keep them stable on their medication, get a routine set up, help them to be able to go back to performing their activities of daily living in a way so that they can take care of themselves. So we definitely see that there's that kind of stability is lacking for them in the community. I think poor people, especially in New Orleans, have really bare bones medical care, mental health care. They may see their doctor, just once every couple of months. And so there's not a lot of hands-on day-to-day check-ins. We do have Act and Fact teams. They're the ones that a lot of this falls on. But the problem is, if they can't find you, if you're not stably housed and they don't know where you are, then they can't help you. So there are a lot of issues around keeping people stable in the community. I think that's one of our biggest lacks here. And listening to Nicole, I was also thinking the other thing that's lacking is there's no support for families who are trying to deal with this. So you have families who are trying their best, like Nicole, this super mom, trying to do right by her son, but there's so very little communication between different agencies, between different entities, between the police and the hospitals, and so it becomes very difficult to figure out what it is that you need to be doing for your family member. And without that support, families often can get very overwhelmed and kind of throw up their hands and say, I can't do it. So that's another thing that happens that ends up with chronically mentally ill people ending up in the jail instead of in the hospital. And they're very vulnerable in jail. Again, the jail is not the place to put someone with a chronic mental illness. They're vulnerable to other people in the jail. They're vulnerable to all kinds of violence, unfortunately. And so we're always looking to be able to get someone back into their community and into a stable situation, and out of the system. Thank you.
Wonderful. Thank you. Thank you very much, Ginger. We're gonna open it up for our panelists to all turn their cameras on and join in the Q&A portion of our presentation today. We do have a couple of comments and comments and questions, but for additional comments and questions, you're welcome to put those in the Q&A function at the bottom of your screen or into the chat box as well. So I'm going to go with the ones that we have already received. Oh, Dr. Hayes,
Yes,
did
we
you
have
have
one more
something?
speaker, Dr. Sarah DeLand.
Oh my gosh. Oops. This is what happens when you don't get enough sleep, y'all. Oh, thank you so much, Dr. Hayes. Okay, Dr. DeLand. Dr. DeLand is with the Tulane Behavioral Health Clinic. She's a forensic psychiatric specialist, and she's also an assistant professor at the Tulane School of Medicine. Sorry, everyone. Sorry, Dr. DeLand. Please go ahead.
That's okay. Yeah, Sarah DeLand. I'm a forensic psychiatrist at the Tulane Department of Psychiatry. I've been there since 1993, and I actually came over to Tulane after I did my forensic training. That Tulane did not have a forensic division at that time. And one of the draws was that within the jail, they had people that were with serious mental illness who had been found incompetent to proceed and ordered to the state hospital. No way of monitoring what was going on. So people were lost in the jail, and like people just kind of forgot they were there, or they fell off the waiting list or whatever, and they needed people to track that. On the other end of the spectrum, we had people that had been found not guilty by reason of insanity and had been eventually released from the state hospital without much in the way of monitoring or supervision. And as you can imagine, there were some bad outcomes with very high profile violent cases that occurred with people who were not monitored or supervised in any way. So I came over to help develop community forensic services for the state, which was going to sort of work on both ends of that, both the people in the jail waiting to go to the hospital and then the people coming out of the hospital. I was listening to the stories of the people talking about, unfortunately, people getting hooked up with mental health after they've been acutely hospitalized or placed in jail. And I couldn't agree more. And in fact, you'd probably be shocked to learn the number of people who had zero mental health contact until they killed someone and ended up in our system. Unfortunately, the victims of those are frequently, of course, the people closest to them. So I also echo the need for families to have as much support as can in treating individuals with psychosis. While most people are not dangerous, there is a subpopulation whose symptoms just coalesce in the perfect manner to create these untenable situations which end in violence. So so we sort of got together and we got a waiting list, and we got my organization has workers that go into the jail and they follow along with people and they try to make sure that they're not decompensating in the jail, that they're getting their medicine and getting safely up to the hospital. Then when they return to the jail from the hospital, follow along with them for a certain period of time. And then, like I said, when people get released from the hospital under court orders, our organization follows them. We have psychiatry, psychology, caseworkers that monitor people in the program. We have a special clinic for it here in the New Orleans area, and across the state. We use various community services that are always in the community, along with our forensic case managers that work along with them, and we work in conjunction with the courts and with probation. We have both people criminally, judicially involved and not guilty by reason of insanities, and we have civilly involved people with people that have been found to be never competent to go to trial. However, their charges are still pending. Their charges do not go away just because the court decided that they would probably never be competent to go to trial. And so those individuals we have under judicial civil commitments ordered to treatment, but they do not have involvement with the criminal court and with probation, with the exception of certain individuals in Orleans Parish whose civil commitments are presided over by their criminal judge. So our experience, as we know, Tulane is also providing mental health services in the jail. So I can attest to the fact that there is a very significant population of chronically mentally ill individuals in the jail. And it's difficult in the jail because the jails do not force medications for any reason. And so some individuals who are too sick to have any insight into the fact that they need treatment end up not getting any treatment or any medication treatment, I'll say, in the jail because they lack insight and because there is no mechanism for the jail to provide medication to someone who does not wish to have it. My organization, we also try to help intervene with some individuals that have been found not competent but are very sick in the jail. And we have tried to intervene and work with some of the local hospitals to get people released from custody for the purpose of going to the hospital and then taken back into custody for individuals that are not eligible to be released completely. And probably the biggest issue for the successful maintenance of the people in the community after they have left the jail and left the hospital is, again, like a broken record, housing. My over 25 years of experience doing this now tells me that an entire spectrum of housing is needed because there's no one size fits all. You know, it's wonderful, you know, the program of like permanent supportive housing and such, which helps get low rent apartments and works with Unity and all of that. And that works wonderfully for some people. Other people need to live with other people because they don't like to live, they feel fearful living by themselves. And other people just need more help than that. You know, they need a type of group home environment where they have, you know, staff there that they can talk to, people to help them with their medication, other people for support, those kinds of things. We also use a Volunteers of America sober housing living option. And as far as residential homes, they come in all levels of care and decency around the city. At some point, people getting residential homes licensed sort of fell off the map. And we had a policy both for the state, all the state hospitals and state-run clinics and stuff, that we were not permitted to send somebody to an unlicensed group home facility because of the problems that occur when places don't have any, you know, oversight. And we can't even follow our own policy anymore because in the entire greater New Orleans area, there is only one licensed adult residential home for mentally ill. Now, there are some homes for the developmentally disabled population that are licensed. Those are a separate category, but in the greater New Orleans area, and I believe that includes St. Tammany, there is only one place that is actually licensed. So, you know, we have to visit places regularly. We will use places for a while and then have to stop because of problems. And that becomes just very, very difficult for anybody who's trying to assist people in finding therapeutic living options, because I can attest to the fact that, in my opinion, I absolutely agree with Ginger that if somebody does not have some type of stable therapeutic housing, pretty much everything else you do is not going to work. And again, that housing is individualized. You can't take everybody and stick them in the exact same type of group home. You can't take everyone and stick them in an apartment. You can't take everyone and stick them in a sober living facility. It's got to be individualized, and I also see that as the biggest, one of the biggest problematic pieces. And with that, I'll stop.
Thank you so much, Dr. DeLand. I appreciate that. And I think Carrie's going to ask all of us to put our cameras on now, and we'll start taking the questions.
Yes, I'm going to do that now instead of before. So forget that I did that before. We're doing it now. We do have some really nice comments that I'm gonna go through the comments in the chat first, and then we'll go through the Q&A. But please, participants, continue to put those questions and comments in the Q&A, and we will get to them. I think the first one that we got was kind of related to a lot of what we've been talking about with regards to housing. And so I just wanted to kind of open that up. So this first comment says, the problem is that there are not enough places to go when these people get released from jail. This individual is with a Fort Worth, Texas County Jail, and housing there is a huge problem. So when someone gets released, they're going right back to where they came from before going to jail. So I think we've kind of covered that, but if anyone else on the panel wanted to make some comments about that.
I'll speak to it just for a second. In every panelist, and what they discussed was a continuum of care. And just in general, I think in New Orleans, we know what works after Katrina, after Hurricane Katrina. We actually built a continuum of care that included PSH housing, some group homes, unlicensed and licensed, but we had a continuum, and we had a network of community partners to work with. What has happened though, as everybody said, budget. We know what works, but budgets have cut a lot of that. And that's so problematic, because in 2008, when we had the tragic killing of Nicola Cotton by an individual who was mentally ill, we put things in place that could benefit these clients. And because of budgets, a lot of that has been cut out.
The next comment from our chat is 2 people have SMI. Patient 1 has symptoms that result in nonviolent behavior. Patient 2 has symptoms that result in violent behavior. It's the same disease. Why do we treat one cohort and punish the other? SMI is not a behavioral problem, it's an illness. Instead of building a mental health jail, we should be building residential treatment facilities. And that's open to everyone to sort of comment on.
I'll make a comment on that. There's a judge in Miami, Judge Richard Leifman, who has done some really, really incredible things in the field of mental health treatment. I saw a film that was produced by Judge Leifman at a seminar he conducted that talked about the mental health facility, or the mental health ward of the jail in Miami-Dade, and it was nothing short of medieval. It was just horrendous. Jail cells built for one person had 5 to 6 people in it, and just horrendous conditions, no treatment, no medication, no anything. And he encountered a member of the council, and together they said, we have to rectify this. And Miami-Dade had 3 county jails at that point. When they started treating their mental health patients properly, they were able to reduce that number from 3 jails down to 1.5. And they also reallocated resources for building another jail, which they had already allocated, to building a one-stop mental health treatment facility, where it could take an individual off the street, give them a place to live, make sure they were properly treated, properly medicated, and then assisted them with their social issues, having an address, getting a job, keeping them stable. And they built that facility. And as a result, they have reduced their homeless population substantially and provided mental health treatment services for the individuals in that community. And it has just been incredibly effective. And those stories are out there. We need to implement those kinds of facilities here because we can achieve the same results. I was just incredibly impressed. I had planned to take a trip to tour it, and the pandemic came, so that kind of put the kibosh on that, as well as the budgetary considerations, but that's still in the offing for me because, I am definitely willing to steal somebody's good idea if it'll be effective. So.
I'll jump in on that question also, and I think that it's more gray than that. I don't think it's a matter of some get treatment and some people get punished. I think there is a continuum of treatment across community tension. I think that it's hard to argue that some people need to be detained for a significant period of time for public safety. And of course, the way that most hospitals are set up are not to be detention centers. Most hospitals in the community are set up to be places for treatment. And I agree that treatment stays have been less and less and less, and probably a lot of them need to be more in acute hospitals. But the issue is that, once somebody is considered stable enough, the fact that they killed somebody and nobody can say that they're not dangerous is not going to be a reason enough for somebody to be kept in a regular community hospital. And I think that many of the people that are severely mentally ill and get arrested for violent crimes do end up in the forensic mental health system as opposed to just in DOC. Although having worked in both systems, I've seen lots of people in DOC that I am very puzzled as to how they ever were found competent to proceed and how they ever got convicted and sent to prison. There are those people that end up there. But they, the goal is to get those people more into the forensic mental health system. And, and the fact is that there are people that are, that do need detention in a secure setting for the purposes of public safety. Those are my thoughts.
I have a question for Judge Reese. This model in Miami sounds very compelling, and I know you didn't get the chance to visit. I'm curious, do you have any sense of whether it's publicly or privately funded?
Oh, it's publicly funded. Like I said, the funds that were allocated to build another jail were recommitted to building the mental health facility. It definitely comes from public.
So that's inspiring, but then it also, to me, begs the question, right? We have lots of different systems of detention. 7,000 people, immigrants, are detained here in Louisiana and housed in private facilities. I think if we can't make the priority for our budget and public funds to create residential housing for mentally ill people, can we channel private funding in? And what examples of any of those exist out there? I'm curious if anyone knows.
I really can't speak to that. I don't have a wealth of information in that regard. The case that I make to the governmental entities is that if you hospitalize someone, it may cost $1,500 to $2,000 a day in a mental health facility. If you incarcerate them, I mean, I don't know exactly what the cost is, but I'm sure it's substantial versus, treating them, keeping them off the streets, and keeping them out of the hospital. You're saving an inordinate amount of money. So I'm not understanding the disconnect from providing those services versus utilizing the alternatives. It's much more cost effective to treat people than it is to incarcerate them or to hospitalize them. And, and I don't want to take the cryptic approach that there are people who profit from it, who want to maintain it. But that could be part of the equation, because just from a commonsensical standpoint, it makes more sense to invest in mental health treatment. You accomplish a lot of goals. You stabilize families. You reduce homelessness. You cut down on crime. You reduce public expense, and for providing alternatives, which are not really suitable alternatives, and there's a dearth of those alternatives anyway. So, I don't get it, but I'm just sitting over here at the court trying to do what I can do.
Great, thank you all. I'm going to move to the next question, which is, and this question is for name the speakers, the presenters today. What governmental entity manages the serious mentally ill?
Hey, Dr. DeLand here. Good question. It seems to be divvied up depending upon what government agency people end up in. We would like to say the Louisiana Department of Health, and certainly their body is would be charged with that, with their various agencies, Office of Behavioral Health, State Hospital in Jackson, State Hospital in Pineville, the various human services organizations in the various areas of the state. Of course, those all used to be state entities. Department of Health and Hospitals, or Louisiana Department of Health, used to have a more hands-on responsibility, but I think you would be hard pressed if somebody were in EPIC-NOLA. I'm not really sure Louisiana Department of Health would take responsibility, as a government entity for those private individuals. So I don't think that question is easy to answer.
I'll just add to that too. Metropolitan Human Services District is the governmental agency, local governmental agency that handles mental health, substance abuse, and developmental delays in Orleans, Jefferson, and St. Bernard, Orleans, St. Bernard, and Plaquemine parishes. And then in Jefferson Parish, there's the Jefferson Parish Human Services Authority. And so those local governmental agencies were created by the legislators and with managed care. And managed care, which is the Medicaid managed care program, came to Louisiana in 2012. And with that, the LGEs were formed, and the LGEs are supposed to be managing those issues in their specific areas.
Okay, good. I'm going to move to the next question, which is, if the funding in jails is not sufficient enough to give people with mental illnesses proper treatment in terms of their regular medication, in-person check-ins, etc., how do we change this? And is there another option for people stuck in situations like this?
So I'll jump in and say, it's a funding issue. It's what the state is willing to pay to give people medicine when they're incarcerated. It's not a big priority, unfortunately, for anyone. I mean, I think we need to start talking about that, that people think that everyone in jail maybe doesn't deserve the same kind of health care they would receive outside. And so it's about putting more money there, I think. But I think Judge Reese made a great comment about this. I think there are alternatives. We know they're happening in other places. We see them working in other places, that we need to start thinking about putting our money into a treatment facility rather than into, for example, another jail, a mental health jail. And I think everyone on this panel, we all would agree with that. And I think we all know that it's going to take kind of just shifting our idea of who's being incarcerated somewhat, and understanding that often our police officers are asked to take care of our mental health issues in the community as well. And that's just not what's best for our people with chronic mental illness.
I want to say something. Last night in my hometown, I'm from Philadelphia, there was a young man that was killed in West Philadelphia due to he had mental illness issues. He wasn't tased, he was shot down and killed. Treating these officers, and instead of approaching it with a more sustainable look at people with mental health, going and talking to these individuals, having a social worker, having a therapist there, or sensitizing training for these individuals who do work in law enforcement and deal with mental health. I think that is muchly needed. I think that's more the funding should go towards that, because we are, like I said in my presentation, we call the police if we're in danger. But more training on those who deal with law enforcement, on people with mental health, and looking for like signs and symptoms instead of just pulling out your gun or pulling out whatever or detaining them, because it makes that situation worse for the individual and the families. So I just wanted to say that little tidbit, because this is just happened yesterday and it's in the news today. So.
If I could comment further on that, the one thing that I noted, and I happened to see the video of the incident, it was posted on the internet, and the community knew the individual and knew that he had issues. The young man's mother was out there on the street trying to talk to him and reason with him, to tell him just to stop. Now, I have to say that NOPD, and based upon my encounters, is doing a better job when they encounter someone with a mental health issue, because they'll bring them to UMC now versus just taking them straight to jail. But we definitely need to do more of that and just incorporate that into the training of police officers, that when you're encountering one of these calls, and maybe, have special officers with special training and dispatch them to those kind of calls versus just handling them like any other, crime investigation.
And I can add that our New Orleans Police Department is trained in CIT. At one point, it was just the officers or the rank that was trained, but I think now those trainings are trickling down to even new recruits, which is a good thing. It still does not take away the problem of when things intensify with our patients and our clients, of how to de-escalate when things intensify, and the use of weapons. I mean, that continues to be a problem across the country. I think it's less of a problem in New Orleans. But I do believe it goes back to that continuum of care, and the fact that for each place our patients or our clients meet, there should be a place or a handoff. They should never not be handed off to another entity, so that care continues for that client. And it's so important.
Can I just add? Oh, I'm sorry. Go ahead. Go ahead, Serena.
I was just going to comment, Lawrence. I think your comments are very well made, and I'm sorry for that loss in your community. One very small step we're trying to take here in New Orleans is holding town hall meetings with law enforcement and people involved in that system. Dr. DeLand was in our last town hall, and just getting people together like this for the moment on Zoom and talking about what is psychosis, helping people to understand the symptoms. So in a situation, whether, you know, entry level or escalated, there can be some awareness. So those symptoms can be treated as symptoms, not as threats.
And I was just going to say, this is, I think it's a people intensive, right? I mean, we need to be communicating with each other, and we need to make sure that, like Dieter was talking about, those handoffs are between care providers, right? So that we're always keeping that continuum going. I think people don't always understand, like, what do social workers do and why are we here and what do psychiatrists do and so on and so forth. But we all have to communicate with each other and help with those handoffs. I see that so many times with the mentally ill clients that I've worked with. They just need someone to hold their hand and get them to the next place they need to go.
Great. We have quite a few questions, so I'm gonna move on to the next one. Thank you all so much for your responses. The next question is, it seems like there's an overall theme of people lacking housing, like sort of as part of this conversation. So clearly homelessness is a huge problem in Louisiana. So what are some of the efforts to change this problem, and how could we as students, so students asking this, so how could we as students get involved in some way to help with this activism?
I could talk as a student. Some of the ways that you can do as a student is advocate. You have to advocate for what you want. I mean, the funding is there. It's just how it's distributed throughout the state or the country or wherever state you're in. We have to advocate to these people who have control of the money and try to advocate it for the right reasons and defund different things that they have so much funding into. You can also, there's a lot of grassrooting. If you don't know a grassroots organization, you can grassroots to organizationize something that is that in the community. Say for the city of New Orleans, you can try to send out text messages, flyers, whole town halls like we're doing right now, trying to get the word out so people can understand that this is an issue that is happening here, say in the city of New Orleans or in the state or in the country, to make this more of aware, more of this of a public issue, more than a private issue with the people who are dealing with this. That is what we can do as a student. Teaming up with excellent individuals like these people, like the discussion panel that I am in, dealing with, talking to them because they have a little bit more power than we do because I'm a student. So they know people that know people. So teaming up with them, talking to them, they have the same concerns, trying to speak out. So you have to find the right people to talk to and know what to do. They're there, you just have to find it. And as a student and as a continuing educating student as myself, you have to have that determination. That's the main cause for this. It's the determination to do the change. That's the only way that's going to happen. If you get the determination to change it.
I just would like to add Janet Hayes, who Judge actually referred to, who is really the impetus of advocacy. If you want to know about advocacy, Janet has been on the forefront of advocating for AOTs to take a more prominent role in how we close the continuum of care and add another piece to the puzzle for how we manage individuals with persistent mental illness. And so she dropped her information in the chat. If you want to have ways of advocating, it would be definitely a person to contact.
I just dropped that in the chat for everyone to see. Also, one of our alums also suggested that students work collaboratively with cohort members when they're in their field placements. that they are a crucial link between agencies who might not realize that their services could be complementary, or ways to provide services more efficiently, and how to cross-train those agencies. So thank you, Angelique, for providing that thought to add to that conversation. I'm gonna jump around just a little bit and go a little bit out of order because we're getting close to time, and there are two kind of issues that kind of haven't been brought up. And one of them is related to juvenile justice. We had, oh, I'm sorry, I've lost it in here. Yes, it says it's also essential that we tie in juvenile court as well to begin treatment as soon as possible. I wanted to give the panelists an opportunity to talk about the juvenile court in this instance.
Yeah, I'll jump into that bailiwick as it were, although it's a little out of my jurisdiction. The AOT statute in its current configuration does not include juveniles. It's only for individuals over the age of 18. I have spoken to my colleagues at juvenile court regarding the AOT program and asked them to consider utilizing it as a tool to deal with individuals who come, before them. What it would take is we're going to have to amend the AOT statute to include a juvenile component, a treatment component. And then hopefully all of the other attendant parts of the AOT statute will come into play for treatment of juveniles. But right now, that's, from a legal standpoint, that's the impediment that I see. We have had discussions with some of our state legislators. Representative Royce Duplessis has been very, very receptive, and Jason Hughes as well, very receptive to our discussions regarding amending the statute to try to implement that. So, but that's the first thing on the agenda, and then the implementation will come after the law provides for the utilization.
So one of the things that happens with juveniles is that when juveniles first present with mental illness or some issues that need to be addressed, that most of the times they bear themselves in school, in the school settings. So most of what happens with children is that the medical profession does not want to label kids very early. So you may see other diagnoses. You might see autism. You might see a diagnosis of ADHD or oppositional defiant disorder. You see all those disorders that when the young person actually gets to about 16, 17, you'll see a more clear, definitive answer as to what their diagnosis might be. And so that's one of the tricky parts of adolescence. And coming into coming into those diagnoses and getting a solidified diagnosis, a proper diagnosis. And that's where Serena's program comes in, EPIC-NOLA, because Serena's program is the program that deals with and addresses first breaks. And it is so important because most of the statistics show that if you catch an individual at the first break and are able to stabilize them, then they have less chronic issues as it relates to their mental illness. But I also wanted to say that there are programs that are in place with, once again, managed care. The Coordinated System of Care for Children is a wraparound program that works with children to keep them out of, in the home and away from out-of-home placement. So the wraparound program in CSOC it deals with kids who are in either at risk for DCFS custody, hospitalization, or incarceration. And so you can go through your managed care plan to get that referral to those agencies. They do absolute wraparound cares, work with OJJ, DCFS, and treatment providers that will actually put a plan together for that child. So that's one thing I wanted to also say.
Yes, and I will put it out there, right? Our clinic, we serve people up after their first episode of psychosis, or as I mentioned at the beginning, ideally before their first episode of psychosis. So when there are those symptoms, We are a place that you can refer adolescents and they can come to us and we watch. And yes, we are very conservative about diagnosing people with chronic and severe mental illness at an early age, but we can watch symptomatically and see if we can manage with medication and family support to keep stress levels low and to prevent their symptoms from converting to psychosis.
Thank you. Thank you. I know that we are getting close on time and we have quite a few more questions to get through. How do our panelists feel about one additional question and then maybe some closing thoughts? Is that okay? Great. I'm going to ask this question because it's something that hasn't quite come to the forefront, but it's what role does ethnicity, race, and socioeconomic status play in adjudicating mental health patients of color in a criminal justice system that is significantly compromised for Black, Indigenous people of color? And given your response to that question, why do you think that is?
I'll venture a comment on that. I think we would all acknowledge that there has been some systemic racism in the justice system, and historically, I mean, going back, you know, through the history of this country. In terms of individuals who have mental illnesses, I think they were just placed. They were victims of that discrimination because their mental incapacities or their illnesses were not, considered in terms of any kind of criminal penalties. So as a result, that has been just a system of injustice that has been historic and continual. I think that now there's a little bit more sensitivity to that. And hopefully now, I don't do any work in criminal court. I'm not there on a daily basis. I practice criminal law, but that was 20 years ago. So I think it's changed a little bit since I was there. But be that as it may, those issues have to be addressed, and judges need to be sensitive. The one thing I've recommended in the Judicial College, and I've also taught in what we affectionately call baby judges seminars, is that judges need to be given sensitivity to those kinds of issues, need to be trained to those kinds of issues, need to try to eliminate any biases or prejudices they may have in those kinds of issues, both in terms of race and color and mental illness, and not just harshly deal with people just because of, that's what you think is the thing to do. One of the reasons I got involved with this because I just saw an injustice. And I think it's a horrendous situation to treat people, and mental illness is just that, it's an illness. And if you involve yourself in it, and if you treat it, and if you catch it early enough on, the people will decompensate substantially and can go on to live, normal lives and contribute to society and have a normal existence and not be subject to any kind of, harsh realities because of their mental illness. So that's something that we all need to be sensitive to, and going forward, we need to pay more attention to it and to make people more sensitive to it. It's not just lock them up and throw away the key. That's not the right way to do it. And it's not practical and it's not cost effective. So.
I'll jump into that a little bit too. One of the things that has been a concern of myself and of Gina Ricasner, who's our LDH attorney here in the New Orleans area, as well as some of the public defenders that I've spoken to, is in addition to the systemic racism that we're all aware of, I've been concerned, and they've been concerned, that sometimes behavior related to serious mental illness is more likely to be considered a quote unquote behavior problem, and especially in sometimes in African American males that we see coming into the jail and coming into some of the local hospitals. And so I think partly what Ms. Dent may be seeing as seems like premature ejection from a hospital. And I'm not saying that that's what's happened in your case, what I'm talking about, but I've seen sometimes been frustrated because I think there's been a rush to say, especially with African American men, that they're dangerous and that it is behavioral, not related to their psychosis. So I will say that I have that concern. I can't quantify it. I can't prove it. It's just a concern of things that I've noticed. Luckily, we do have some people in the system that are aware of it and working to try to handle it as best as we can and educate and document and all of the above. Thanks.
Yes, I mean, part of the reason, I invited Nicole to come on and speak is because I think her story of Brian's journey exemplifies all the systemic injustices that we face. And she is a mom who is actively involved in her son's care, connected to a clinic that is academically affiliated, that is resourced and connected throughout the community, and none of us have been able to help her son. That's a problem, and that's why these conversations are essential to continue.
I think that feels like the appropriate way to wrap up this conversation. I apologize to all of the questions that we have in there. I have saved those. I will send those over to Dr. Hayes. Maybe we can take a look at them and perhaps answer them in a follow-up email. But I'm gonna let Dr. Hayes sort of close us out.
Thank you, Carrie. First of all, I want to say thank you again to Nicole. I really appreciate you. I really do. And, my heart tugs because I feel your journey. And I've been through those journeys with parents before, and it can be so frustrating, but hang in there because you have a lot of people who want to help you. I saw in the chat, I think we got people added to your team. So thank you for sharing. And also thank you to all of our guests. Everyone here who is a panelist has a special place in my heart because I know the quality of their work. I know the fact that they are all in 100% passionate about helping individuals with chronic and persistent mental illness. And I understand that the journey continues and that, this information needs to be out there because people really need to understand that it is an issue that takes ongoing advocacy, ongoing funding, and ongoing analyzing of how the system works and where the gaps are and what needs to be added. So thank you guys so much. I really appreciate you, and I look forward to our next virtual health spot. And Janet, thank you for all of your comments.
Thanks for having us. We really enjoyed it.
All right, thank you, everyone.
Bye.
Thank you.
Thank
Yes.
you. Bye-bye.